Welcome back, everyone. Saw a nice-sized group on the walk and talk with Sunny Vu, along with the very popular mascot of Medicine X, Zoe. Well, now let's hear a fascinating discussion about #WhatifHealthcare with panelists Regina, Holliday, Meskó, David Van Sickle, Michael Seid, and Stephen Friend, along with moderator Paul Costello.
Everyone, welcome to the session this afternoon. My name is Paul Costello. I'm Chief Communications Officer here at the Stanford School of Medicine. So this session is about dreaming, a dreaming session. And appropriately, in the mid-afternoon, this is the time to paint a portrait of the world we want in healthcare. What if? So let me begin by asking all of you, why don't you all first introduce yourselves so they know?
Oh, I'm Regina Holliday. I am the artist painting out in the hallway, and you might have seen some jackets that are in here. They're members of the Walking Gallery, which I founded.
My name is Meskó. I'm a medical doctor with a PhD in genomics, and now I'm working my way to becoming a medical futurist. But anyway, I've been teaching medical students and doctors about social media for 6 or 7 years now.
My name is Michael Seid. I'm a behavioral and social scientist. I'm a professor at Cincinnati Children's. I use applied behavioral and social science to try to make the healthcare system work better for kids with chronic illness, and I'm co-PI of the C3N Project.
Stephen Friend. I am president of Sage Bionetworks. That's a nonprofit foundation whose mission it is to encourage the dissolution of the current guilds of experts and making it such that broad teams sharing data, patients, scientists can work together to enable solutions that can't be occurring otherwise.
And that's going to happen how quickly?
Some things happen already, but it's amazing how that tipping point in terms of doing that is dependent upon what question you ask about that.
Great. Hi, everyone. Great to be back. I'm David Van Sickle, trained as a medical anthropologist and a respiratory disease epidemiologist. And a few years ago, started a company with some friends called Asthmapolis that's now known as Propeller Health, as we've broadened to address both asthma and COPD.
And David's from the great state of Wisconsin, Madison. So let me begin by asking you, there has been often mentioned in geopolitics a reset button. For instance, Secretary Clinton said to her Russian counterpart when she met a year ago, how do we reset relations with Russia? So I wonder if we took that concept to healthcare. What if each of you had a reset button in healthcare? What would we see and what would be different? Regina, why don't we start with you?
Oh boy, this is exciting. I would see patient participation being key to every structure within healthcare, that we be part of the design phase of implementation of all kinds of care, an active part of the care team, and of course, we must have complete and real-time access to the electronic medical record.
And so I presume that you say that now, where in that barometer is patient involvement?
Not in the room at all in many cases. So just like the painting I painted with all those cute children that's all over this conference, that's a reflection of within art. Very often children were just a prop within a painting, within fine art. Well, in the world of medicine, patients often exist as a prop and not necessarily the entire view of what the medical team should be focused on. So we must change that worldview and all of us truly be at the table.
Percy, if you had this reset button, what would be different?
Wow. If I had a chance to use this button, I think I would include digital literacy in the medical curriculum from the 1990s, which means by now every physician worldwide would know how to use the internet or social media and how to help their own e-patients. So we wouldn't need to organize such conferences.
I often wonder if the patient is so far ahead of the physician in social medicine that there's this huge gap of of frustration, perhaps, that Regina feels and that you feel personally. Can you talk about that, the gap between the patient knowledge and the physician?
Absolutely. For the last 7 years, I've been teaching medical students about social media, as well as medical professionals, even professors. And I believe that we cannot expect them to know how to use these channels if we don't train them to be able to use these. We cannot expect them to know how to deal with an e-patient if we don't train them for this. So in my course at the medical school of Semmelweis University, I teach them through real practical examples and step-by-step guides about first how to use social media themselves, how to be up-to-date, how to use search engines better than their own patients, and then how to help their e-patients, how to transform a Googler patient into an e-patient, a real partner in the treatment. So it requires time, effort, but in my experience, whenever I show them real examples from practice and from the clinical perspectives, they were absolutely persuaded, from the 20 years old medical student to the 65 years old university professor. They can be quite easily persuaded if we give them real examples and practical solutions.
Michael, what if you had this reset button?
I'm going to go back further than the 1990s. So it's a historical artifact that medical schools grew up with the divisions of biology and chemistry. It could have been that medical schools were in the College of Arts and Sciences, and I would reset to that button. I would reset back there. If we had doctors who were trained in sociology and humanities, as well as chemistry and biology, I think we would be having a different conversation today.
And what would that conversation be? How would that conversation be different?
Well, I think one of the things that one of the things I notice is we're very technologically advanced, and we also all believe. This is my okay. We're among friends.
Go for it.
So.
No one's listening.
Yeah, all right.
Nobody is doing anything out of it. Nothing leaves this room, right?
So a lot of people think because they're human, they understand people, and that's like that's like me saying, I have a heart, and therefore I'm a cardiologist. So I think a lot of times what we've done is we've sort of created this medical system that's a really good wealth transfer system. It hasn't really been designed as or supported to do much else. The care that gets done is done on the backs of really well-meaning, hardworking people who are struggling against the constraints of the system that they find themselves in. And I think that if the care system had been designed for humans, then we would be having different conversations today. We wouldn't, as somebody said, we wouldn't need this conference.
Mm-hmm. Stephen, what about you if you had this reset button?
I want to make 2 points. One is that there has, for the last several hundred years, been a sort of understanding that when you go to a physician, in some ways, that person is expected to do the healing. And in that relationship, and I think in a potentially negative way often, there's the heal me. And this leaves patients often as voyeurs, disengaged. And I think the first point is that reset button would answer a question that Jeff Hammerbacher, architect for Facebook, made about 3 or 4 years ago in San Francisco, where he said, I just don't understand why no one cares what happens when I take this pill. So I think one of the aspects of that reset button is to have a scenario where actually you realize that everyone does care, and all that information, not some of that information, but all that information needs to be collected. The second point that comes from extending what went on in the morning session is that I think a lot of the dialogue here so far has been the concept of a dialogue to a conversation, citizens, patients, and the medical profession, the doctor. I don't think that that's actually going to work out. I think that actually...
It's going to work out. Wait, let me stop you for a minute. It's not going to work out for whom and what.
I think I can get there. Sorry. But what I mean is that dialogue between the person who is delivering healthcare and the patient, I think will need knowledge experts that are actually looking through vast amount of clinical information, real-time information. That is, I think over time, we're going to have a third person, a three-way conversation. It's the citizen who is able to have a role in telling exactly what's going on, giving their passion, giving their insights, not just to their doctor, but also to a system of people who really care a lot about that disease and what's going on, that actually are not trained the way physicians are trained, but are trained to look at very large data sets, where it's possible to take the sort of occasional anecdote and build signal out of anecdote. And the physician sitting in the clinic cannot take anecdote up to insight. And so I think it's going to be citizens with physicians, with knowledge experts, people who know how to mine data, working together. And I think that reset button should bring in that interested party, not just physicians and citizens.
Okay. David?
I'd wish for bigger dreams, bigger, sharper dreams. To be specific, I think that in the case of mobile health right now, it risks becoming this kind of digital safari where there's discomfort in sort of such lavish proportions that only the rich can afford it, and that makes me uncomfortable. And I think about the great public health successes that we all fought for, my predecessors, our predecessors, and those were very long and hard battles. And so personally, what I would wish for is less sublimation of health to the individual. I don't think that. I think that's kind of that's weak and oppressive, and we can do better than that.
Where do you see this gap? I mean, you're talking about a gap in healthcare that you think is going to, I presume, grow. And where do you mostly see this gap? Where's it most apparent?
I think it's in vision. I think it's that will we be a successful company if we make it easier to better manage asthma? Yeah. Will I die thinking that was a huge success? Maybe, but will I die thinking it was a huge success if we just actually got rid of it and eliminated it? That's like kind of what I want to happen. I don't really want to get people more engaged with their disease. I'd rather just kind of eliminate the need for them to have to ever think about it happening.
What about that, Regina? It doesn't want people to get more engaged with their disease.
Well, having the vision of complete eradication of disease is a spectacular vision. The one thing that we have to keep in mind is at the same time, that's a giant leap. We have to make sure the foot on the ground person, the reality of the life that we live, also be addressed. So some of the simplest things could be done right now to change infection rates, to change things like that, aren't happening. The little visions we can enact next week aren't occurring because a lot of people are saying we have to put off and go for the giant vision. And unfortunately, it takes a while to attain. So it's good to have that as long as at the same time you're going for the things you can actually succeed in rapidly.
Go ahead.
I think along those lines, one of the things that, from having worked in academia, biotech, and industry, is that the ability to take an insight and turn it into a new care, that is, to take scientific knowledge that gets generated, a new insight, and make that so it actually changes practice. I think we haven't learned how to do that well. So let me give you an example of something that I think may be a start at that. There's a project we're doing on rheumatoid arthritis, and it involves 10 different clinical trials. It involves citizens giving their data up into the cloud. And that data is all going to be up there on anti-TNF therapies. These are the drugs that make the evening news reports, go around in the advertisements. And there's a question that you probably know that only 1/3 of the patients benefit from those. So it would be nice to take approved drugs and get citizens to actually give the insights and ask whether those drugs maybe shouldn't be given to all those patients. And that type of effort, if you make that loop from put the data up, which we're doing, we're going to put it in the cloud, we'll let anyone in the world work on it, and as a nonprofit foundation, then do something, has to connect with regulatory agencies.
How do you do that concretely? How do you accomplish that? So draw the map.
So imagine 10 trials, several thousand patients, and here you have genetic information, and you have what drugs they got and how they did. Put that up in the cloud, and you have a place where people can go and query it. They can make a discovery. They can say, this looks like this causes this. This looks like this might be a reason why this is happening. And then you can run a leaderboard, and instead of having peer-reviewed journals deciding what is worthwhile, imagine a way where the leaderboard says, this is the best answer statistically, and that can then go in to a trial and run a second trial, a validation trial, to see whether in fact that works. And the point I wanted to make is when you do that, it's really important to realize that most scientists stop at the point that they make their discovery. They do not connect it through to the regulatory agencies, which must say this is something on which a medical decision, a payer, a physician could do something. So I think we've got to make that whole loop, citizen up through the data, through the regulatory scientists.
Michael, you're nodding your head.
Most scientists stop. And I was reflecting with my brother yesterday. I was visiting with his family, and I said, if my job is actually to get grants, and not in my current job, but previous jobs, it was to get grants. I don't want to just get grants. I want to actually fix the world, or parts of it. And the idea of massive participation is really compelling. The issue is making the tasks modular enough so people can work on different parts of things, making the work granular enough so that anybody can participate easily, and then having an integration platform that makes it easier to aggregate the individual knowledge. And I think having something like these aggregate trials where people can basically what you're describing is log in and play with the data, try to come up with something, and then have people being able to participate in rating that and distributing the task of peer review as broadly as possible, I think just makes things go a lot faster.
Percy, I'm going to throw a question to you. I was especially intrigued by this that I read online from Nick Dawson, who's here. Every time I use Uber, he wrote, I wonder what's the equivalent in healthcare. Frictionless payment, house calls, call me by name, no forms. So what if you could create the equivalent of Uber in healthcare? What would it look like? What would it be?
Thank you for the question. I will go back a few steps, referring back to the visions and dreams in healthcare. I think that medical professionals, or at least the majority of them, they have lost the ability to dream big because of the day-to-day problems and complications. So, but now with the help of digital world, from mobile health to social media, they could have a chance again to dream big. So now I think the first step is to give this ability back to them so they can dream big again in healthcare and come up with innovations. But the best thing I can think of is if I had to summarize the best potential future of healthcare somehow in one tweet, then I would come up with something like healthcare should be transparent, online content should be curated, patients, all of them should be empowered, medical professionals should be web savvy so they can deal with all these e-patients and digital channels, and the collaborative barriers should be gone forever. And maybe the last element is the only point here which is already now available. That collaboration now is really worldwide, but all the other points are missing. So I wouldn't like to dream big now and come up with a huge example, but I would like to do some small steps first, because it takes always more time to bring innovations into healthcare because of the evidence-based approach, which is understandable, but that's why we have to take very small steps one by one. And first, giving back the ability to medical professionals to dream big, and second, to prepare them for a world full of e-patients and digital technologies.
Regina?
Okay, so this is already being done in pockets across the United States. So for instance, a case study model would be, look at New Care in Lawrence, Kansas, run by Dr. Ryan New. What he does is a direct pay primary model, fulfills the needs of a huge segment of society that have a huge insurance payments that they'd have to make, like copays, are out of sight if you've got a high deductible plan. So he's going to take care of you. He's going to see you. He does house calls. He's on Facebook. He's on Twitter. He does blogs. And he's on YouTube doing educational videos about how you can take care of your diabetes care and things like that, right? Amazing. And this is what's happening with social media and new technology is, forget about islands of excellence. We're talking about viral growth of excellence. Individuals now have been freed to use the technology that allows for them to show their amazing insight to the world so everybody can learn about it, inspire others so they can create that. The need for gigantic organizations that made, unfortunately, a lot of mediocrity continue is going away. And the individual citizen, be they doctor or patient, is taking over. And that's the future of social media, and that's the what if we're talking about.
Do you see social media? It's almost like when you're talking, I'm thinking social media as an enzyme that just sort of dissolves the existing structures.
Yes, like I talk to people, I'm like, I honestly think 10 years from now, the entire nonprofit sector could actually be destroyed as we see it today. Because it's based upon the idea of really large systems, right? Systems of organization. And just like the music industry has been destroyed, and the traditional photography industry has been destroyed, it's going to happen throughout the entire ecosystem that we currently do business within. And that's where you're seeing crowdfunding take off and angel investment take off, because individuals now are not separated from the goal of attaining the care that they would like and changing the world the way they would like to see it changed.
Do you have a reaction to that?
I would add one piece to that, and that is that there was a time in 1,000 years ago, 100 years ago, when the medicine man
Yes.
was the center
Snake
of
oil.
the giving of health. The physician, who has been in that role, and I can speak as having been one, was playing part intimate caregiver, collector of information, and knowledge expert. As remote sensors and other mechanisms come about to give information, okay, to collect information, and the ability to put that information together grows, there becomes a third generation that is sitting there that has to be next to a caregiver, but that knowledge expert is one that I think is not necessarily in the form of a physician. And I think that in that dissolution that you were talking about, the enzyme, somewhere there has to be a large set of knowledge, which is about the rules that are governing disease and making it so that the particular person can follow the contour for them between wellness and health. And we're used to our GPS systems giving us information about how to track where we go. There will be medical GPS systems that allow you to track yourself where you're going. But what's backing that up is not social media. It's not the medicine man. It's not the physician. It's the knowledge expert. And that doesn't mean that there isn't a key role for a physician, but it's a different role for a physician sitting next to that knowledge expert.
Let me throw out a question for all of you, which is especially significant because of what's happening in the next week with the Affordable Care Act and Obamacare going into effect. What if price wasn't an issue for seeking care? This is from Anita. What if price wasn't an issue for seeking care? What if?
I think that's actually part of the problem, right? Price hasn't been an issue to seeking care, and so making cost more transparent has been a key part of a number of commercial models, and I think it's important, and not just cost in terms of care seeking, but cost of enduring kind of the stifling burden of a disease sometimes can be huge, household economics. So I'm encouraged by transparency and price, but I don't think it's going to be a huge sort of lever for us.
Why not? Why will transparency not be?
I think that it will potentially allow consumer-directed decision-making in healthcare to be more efficient, more effective. But I fundamentally think that with regard to sort of big efforts, it's going to take more than sort of big accomplishments. It's going to take more than that. It's going to take, like, eradication of smallpox was a huge effort, right? And it's a collective decision that we make about banishing suffering and specific conditions. So I want to see that kind of an effort and not sort of the transactional visibility of pricing.
Stephen, what if price didn't matter? What if price wasn't an issue for seeking care?
I think
Pie in the sky?
Well, no. What I think about is I'm not too excited about that, and I think the concept of having rewards for wellness is really important for being able to stay well or to keep people well. But in the immediate situation when an emergency is going on, what I see is physicians, and I would assume also patients, wanting everything. Right? This is my loved one. Right? Give me this, give me this, give me this, give me that. So if it didn't cost anything, and I forget what large fraction of the GDP we spend on healthcare now, 27% or whatever, I could see that going up. And so I'm not sure that having it where the price was not an issue, if that's what was meant, maybe I didn't take the question the right way.
So how do we turn that dynamic around in this new world of healthcare, constraints, limits, less dollars? What if you were in charge of turning that around the federal government? What would the steps be that you would take? I mean, how do we begin to address some of those big issues of money that you're talking about?
The amount of resources that get put on the most sick and the fairly sick, and not on those who could be sick or be getting sick, is because we don't have the way to capture that information to work with those individuals. And I think that what I think would be awesome is if citizens realize that a key role they could play was in actually having those live feeds that could give better clues of that almost well state and slipping in and out of that almost well state instead of when you're showing up in an emergency room. So if I was thinking of ways to look at the cost to have something work better, I think it would be that we've talked about the importance of prevention, but it's actually really hard to work with prevention unless you have some sense of what that sort of board looks like. And that's because we don't have the information coming in from individuals who are going in and out of that state of almost wellness.
A reoccurring question that has been on Twitter is, and one from Kathy Nieder, what if the electronic health record was meaningful, readable, and informative?
We'd all go home.
I see there's a lot of what if, Regina?
Okay, so in the retail business world, which was what I was part of for 16 years, we at this point have gone through, like a toy store, for instance, where I worked, would have had 6 installations of POS systems in the past 16 years, 20 years. You know, we had gone through system after system, done reinstall, got it better and better. We don't sign contracts that don't have a complete data ability to switch data from vendor to vendor. We would never sign a contract that would make it where we couldn't disclose problems to the public, that the system doesn't work. That would never happen in a toy store, yet it happens in medicine all the time. So you got the EMR that you wanted to create, right? By not researching, by not talking, by living within silos. Now we have to change that. And panels like this and people like you, you're the ones who change it. Because you're forcing vendors to start talking to each other, hospitals start talking to each other, and patients to let it out of the bag as well. And that's how we change this kind of behavior.
And talk about that change. Talk about where that change. You said in forums like this. Talk more about how you generate.
Oh, they're tweeting. So, you know, it's amazing. We're going to say stuff on here, and it's going to totally haunt us maybe 3 months from now. You know? And we're, right, yeah. And so we're going to
Everybody's eyes are down. That's
right. It's
great.
like tweeting. And it's a world-changing element that's happening right now. And it's happening in real time.
Can I push on it? Because this last weekend I saw a nice quote from Wei Wei, the Chinese artist, that said, an action is worth a million thoughts. Okay? An action is worth a million thoughts. And tweets are sort of like thoughts. Okay? So I think it's going to take more than tweets.
Oh, but tweets are like the...
So those who are tweeting?
See, when you have the plague, you know, like there's symptoms, like the boils start popping out. Tweets are totally the boils, okay? it's like, this is the early sign of the massive change to come, because people on Twitter, they don't just think, they act.
Right, but I think very much agree. But I guess the question I'm asking is, what are those actions that could come from the tweets?
Oh, okay.
So how do you translate
Okay, so
what
what happens
what
is this
is
thing called a
healthcare?
flash mob. That's one of the things that happens. So all these people, they start getting really aggravated and irate, and they start thinking about concepts. So maybe they start a picket in front of the American Hospital Association because they're not actually talking to patients or wanting just to have access to our record within, less than 30 days.
Yeah.
Those are the kind of things that you organize on Twitter, and they happen within 24 hours. That never happened before. You used to have a huge organizational system to get people out and acting. And now, because of Twitter, we are talking to each other. I mean, I met the Robert Wood Johnson Foundation via a tweet about Open Notes. I knew about the Open Notes project back in 2010 because I tweeted about it, right? And that allows for me to go to medical conferences and tell other hospitals about Open Notes way before the study becomes public. And then those people, guess what? They're primed. They're ready to go. So when that study comes out, they embrace it. And they say, we too want to have Open Notes. And it becomes viral. It starts to spread.
Don't you love her energy and passion?
Thank you.
We need more of you in this world.
Yes, let's do that.
Let me ask a question that was raised, a question that was raised before, which I found very interesting and compelling when Sam Gordon spoke in the last panel. And, he talked about palliative care and end-of-life care. And as we know from what happened during the debates of Obamacare, it was trashed by the right and put into death panels. And the question here is, what if the end-of-life care and palliative care was part of all medical school training? What would that mean? What would the impact be? Bercy, you're an educator. What would it mean?
Are you sure you want to ask me who lives in a country with socialized medicine?
Yeah.
Thank you. It's a different system, absolutely different system. Well, just like some basic elements like medical communication. I'm not talking about social media, I'm talking about medical communication, which should include both real life and online communication as well. These elements should be the absolutely basic part of the medical curriculum, just like using electronic medical records. And as students, I was trained as a medical doctor. I finished medical school in 2009, and I came out from medical school being a doctor, and they never trained me to be able to deal with the internet, any digital channels or technologies, e-patients, nothing like that. It should be a part of the absolutely basic training, and it is not. But what I learned through being a geek and living online all my life, through individuals, you can make things through. So it took me several months to persuade the members of the university board at my medical school, but finally they let me do a pilot project and include a basic element, online communication, in the real-life curriculum. And they told me that if I can show them real results, that this course is successful, then they will let me do my stuff. They gave me free hand. And the success was absolutely clear, and all the students loved the course, and they learned a lot throughout the 13 weeks. So since then, I've been doing the course. I believe through these practical examples, we can bring these elements into the real-life curriculum, but for this, we have to start acting now. I could have been saying for years that digital literacy should be in the curriculum, but instead I spent several months and efforts and time, energy, and money into this, and I made it through. So I believe we need these people at different medical schools in the world, and we have to make these things to happen in real life.
And you've got to go a little bit deeper than what you just said, too, which is at home when you watch television, if you actually still watch television, you probably do it in that room called the living room, right? Okay, the living room was once called the formal parlor. And what the formal parlor was for was the laying out of the person who was going to die so they could be receiving guests, and then the laying out of the dead prior to the funeral. We had to rebrand that to the living room, okay? We took death out of our life. So it's not enough to have instructors teaching you this in school. We've got to bring culture shift. And so I try to get Hallmark to create hospice cards. But I want you to all work on your ways of trying to get the public and the culture to embrace the concept that we're all going to die someday. And we're going to have to talk about it. So whether it's you tell your friend about My Directives, where you can go online and actually pick your care team that's going to make sure the end-of-life wishes are respected, you find a way to have that conversation via Engage with Grace. At your Thanksgiving table, you get everybody at that table talking about, this is how I would like to die. And I want you to respect that and make sure I get my wishes fulfilled. If we don't have that conversation in the home, we're not going to get the change we want within the world of medicine, and not in the medical school either.
Anyone else want to jump in palliative care? Great point. Excellent point.
Anybody else want to follow Regina?
I would like to add something if that's okay. I'm sorry, I know you're not asking for audience things, but
Hey.
my name
voice.
is Renee Berry. I just wanted to say that palliative care is not limited to the end of life, and that it should have a seat at the table from the point at which someone is diagnosed with serious illness. And that I agree, culture change, we need it, right, in every piece of the puzzle, but I think that there's a specialty, right, that focuses on this, and that clinicians deserve to learn from the specialty to have straightforward conversations with people about what their goals of care are, so they can have the highest quality that's really designed for them. But okay, no more
Thank
about
you.
palliative care.
Great, thanks for that. David, you were talking before about well care and not sick care. And one of the questions on Twitter is, what if we had well care, not sick care? What would that mean? What would that mean? How would that change the dynamic?
Do we have sick care right now?
Pardon?
I'm sure. Do we have sick care right now? I mean, there's a whole bunch of people who actually can't get care, period, whether it be well or sick. That's part of the reason why we're having Affordable Care Act. I mean, right now, we have a whole bunch of people in this country who do not have access to care. Now, some of the ways they don't have access to care because economically they are not a place where they can get it. They do not have access to care because they have been taught generationally that they do not deserve it. And you've got to fight that battle as well. So you've got individuals out there who don't go to care at all because they've gotten an idea in their head it's far too expensive. They can't be part of this. And well care will never even have a chance if we can't get to the people to the point where they feel like they can accept care when they're sick.
Yeah?
You speak with great passion.
Yes. Third generation non-insured.
The cost, and I agree with this importance of care. The thing that I'm struck by is something that starts as a small symptom that grows to the point where now you need 4 days in the intensive care unit and $30,000, $40,000. I want to make sure that we're also looking to make sure that everyone has the ability to have those things that could prevent those things from evolving into catastrophes. So I think there is no question there's a lack of care. I think the medical industrial complex is infatuated where the money is being made in those high cost days. And there is great benefit from getting care out to people that isn't in those last days. So I think that to say that that you should have a weighing of the scale between whether acute end of sort of catastrophic intervention versus prevention is sort of a shallow one. I think actually they both need to occur.
Right. And we need to get nurses back in schools. Right? I mean, if the kids can't even get care in a school setting where there's their only access to care oftentimes, how are we going to get care for the population? Because they're gone. You know, they've been pulled. Like at my school, the HSA, the parents paid for our school nurse to be at the school for a full day. Otherwise, there'd be no care at all. My son's school is a Title I school where we just got the flu miss shot. Thank you very much, Garrett County, Maryland. Because they cared enough about those Title I kids, they made it happen. So if we're going to have wellness in this country, we're going to have it by helping people implement it, but you have to do it at the exact same time, right, as the sick care itself.
Well, this leads into this question here, which is, what if we had diversity in care teams which represent the populations they treat? A big gap, a big problem in this country.
Nice
Well,
question.
yes.
Who wants to grab that?
So, you know, I think that I'm going to say something not politically correct, which is that a lot of these questions they're great solutions, but part of why I like the dreaming is it as a prelude to doing. And I feel like a lot of times, I agree that the ideas are important. The narrative, the meaning that we create is how we actually know what we're supposed to be doing here before we die, and how to actually be. I think a lot of times we have ideas that make a lot of sense. What's missing is knowledge about how to actually change the system.
How to get there?
How to get there. And you know, that's really, really difficult because the system pushes back.
Right.
I mean, you talked about, you know, the question of what if there's, you know, if price was no object. There's a lot of money in healthcare, and a lot of money means a lot of energy to maintain the status quo. And so the question, you know, that I wrestle with is you know, I guess my what if is what if there was a way to actually make change. I think some of what I struggle with personally is how do you take you know, how do you take these ideas and translate them into the next steps? This is why I'm so you know, enamored with this idea of peer production, because and I think, you know, what we're talking about similar things. We're talking about sort of viral ideas and then viral tools and trying to distribute the work of change as broadly as possible. I don't know exactly how to do that, in all honesty, but I feel like it's, you know, that's what needs to happen is actually trying to get the right tools in the right people's hands, so that people, by actually solving the problems that are important to them, they're making the changes in the system.
Nodding your head.
I'm with you. I'm actually thinking about, so like a big lesson to me in my life has been that from the space program, actually. So you think about, you want a huge goal, right? And you have no idea how to get there. So you break it down and you do Mercury missions and you learn like some fundamental things. And then you do Gemini missions and you build on that. And then you do Apollo.
Yeah.
And over time, it's accretive. It is not just like wholesale flipping. But first you got to learn how to like ride a giant rocket and have it not blow up. And then you've got to figure out how to, you know, get out of the thing in space. And then you have to lay down foundation after foundation, you know?
Yeah.
So I completely agree.
Yeah.
I find the question itself, when you look at this panel up here, deeply ironic.
Say it again. I'm
I
sorry.
find the question itself deeply ironic when you look at this panel up
Bunch
here.
of white people.
So there's a bunch of white people up here, and I think I'm the token female. I may be also the token economically not doing so well person as well. So if we really want to change things, this has got to change. I want to be out there painting canvases where I see a way, way more people of color in my canvas, and I'm not having to fantasize that. Yes! Shout it out! Okay, and then economically diverse. I mean, I do like the fact at this conference, there's a whole bunch of e-patients, and if they're anything like me, golly, macaroni was the food of choice in the month of July. But we have to be more part of the conversation than we are right now if we're going to change things.
Great point. Back here, taking questions.
Hi, I am Andrea. My blog is Brave Bosom, and I want to take it back to the practical. So Twitter handle is the same, Brave Bosom. I'm going to tell you my story. I'm here because I am trying to find ways to share my data as a previver. What that means is I was told when I was 25 years old that I had up to an 87% chance of getting breast cancer. So when we're talking about prevention, I'm your audience. And I'm also interested in practical ways that I can do that. After this year learning that our BRCA data, our genetic data, was actually treated as a trade secret by the company that did the test for us. For the first time in history, now that we've overturned those gene patents, we're thinking, gosh, as a community, how can we share our data? What can we do? And it's so far from where we are today. So I wanted to ask this question back to you guys, especially to Stephen Friend. What are the practical ways that we can do that? What is the immediate thing that I can do where I'm actually treated as a partner and helping to design something in the immediate future? It doesn't have to be the big picture. It has to be a step forward in the right direction.
So thanks. Some of the work we do at Sage Bionetworks is to make it so that citizens who want to share their data can put it up there for anyone to look at. And to do that, you have to make it such that the laws about sensitive information are properly addressed. And the beautiful thing is that actually review boards, internal review boards, IRBs, will put together ways where that actually has the right rules for data going in and being able to work with that. And so we and other groups have worked on ways where when a patient says, a citizen says, I want to be able to share my data and I want everyone to get to it, it's now possible to host that data in the cloud. The alternate, which I will bring up, is that sometimes there are companies who actually want to collect that information so either they can sell it to others or keep it to themselves. And I think that as citizens, we should try to make sure that that data is flowing as much as possible. The work that John Wilbanks did on portable legal consent is a nice example of an effort to ensure that someone could go through the sort of learning, teaching, to be able to do that. I think that the interesting thing is that the data will have a tipping point of value when many people say, I want this data for others to work on, right? Not just to store, but to be able to engage, to use that data. And I don't think that's that far off. We were talking about small steps. That's a Mercury type of step. That's not an Apollo thing, which is where people say, you know, that data that I can't get off my a heart monitor, I want that. You know those stories. We're pretty close, and for those who have that power of using the tweets, those types of things, and organizing around particular, I would love to see the passion that's there going into almost like an agenda. We have 6 items that we're going to go after this year with regard to freeing up data or that. And I challenge those who are, I think, have that ability to begin to be structured in what we're asking for and looking at those as campaigns, brigades of people going, I want this data out there, I want that. And I think, to your point, that's feasible to do.
Also, Blue Button. I mean, Blue Button's changing things. We're going to have the ability to get those baby nice-sized files, and then once we got those nice-sized files, we can send them out. And this word de-identified, a whole bunch of people in the rare disease community, we could care less about de-identified data. We want data. And a whole bunch of us, the default is choice. The default is not privacy and sharing. It is choice. You get to decide what you want to do with it. Now share it with the whole world if you want to.
Thank you.
Thank you.
I'd like to pick up. My name is George Dawson. Until about a year and a half ago, I was CEO of a large, fully integrated healthcare system in Virginia. And I want to pick up on this data theme and give you my what if. So there's about a 30% unexplained variation in outcomes and the cost of care across the United States. That's true from system to system, from doctor to doctor, from organization to organization. There is no real correlation between the money spent and long-term clinical outcomes. You don't have to take my word for it. You can look at the current issue of Harvard Business Review, look at Michael Porter's article if anybody's read that. We spent the last, 4 years debating the future of healthcare in this country, and somewhere in all of our work, we forgot about collecting data and having using that data in an applied way to tell how much we're getting for our money and how we're spending it. Not only do we not have good outcomes data and good cost data, we don't even have good price data. Most hospital systems, including the one that I used to run, are loath to publish their data, even if they really know what it is, what their prices are for various services. So I'm intrigued by this idea of the use of the cloud to get at that. I'm intrigued by the idea of if we're talking about patient-centered care, let's start with the question of how this country is going to pay for the care that we all want and deserve. There is enough money, but there's not enough money to keep on doing what we're doing. And so I'm interested in the intersection between health reform, the meaningful use of outcomes data and collection of that, and how we develop public passion around a subject as mundane as data, not just on outcomes and not just on treatment of breast cancer or pancreatic cancer or heart disease, but also on how we're spending money for chronic conditions and wellness care. So that would be my what if. Does anybody have further ideas about how we could really change the world in that direction?
Well, one thing is, if we look back to Martin Luther and when the Bible got read in German, people got really angry because they were getting lied to. So if you start releasing the data in small pockets to where patients can actually read the records, one thing that's going to incite change is anger. Because once people read their records, they're mad. There's a lot of data that was not utilized and a lot of medical error within that. And so one of the major things is open that stuff up and spread it if you want to get rapid change.
One quick thing, there's a woman in the Bay Area, Olga Wordby, that had worked with Whatifhc, and she got her son to do a project where it was called What's the Price of Chicken? It was organizing all the children around the world to figure out what was the price of chicken. And I think that was really an important project. But imagine one where what's the price of, okay, was citizens putting out their own information, since everyone knows what those bills are, and having a way where you could get to that data. And yes, hospitals will put it out and others, but I think so much of what we need is to have the energy, the passion, the level of activation of citizens raised from it being some to the many. And I think those types of campaigns that could engage many citizens, that could go viral in terms of how much did you submit all the bills that you had, because we're aggregating what was the cost of a mastectomy, what was the cost of that. Not because it was from one hospital. You could see that all of a sudden, up in the cloud, becomes a picture of reality. That's transparency.
And that is happening. I was thinking of Martin Luther before Regina
That probably
brought
came
him
from you
up.
then.
Yes, you were getting my Vulcan mind meld. Casey Quinlan at Mighty Casey on Twitter. My simpler hashtag is hashtag how much is that? I'm not going to ask a question. I'm going to issue a challenge. Let us do that. We are doing that. Watch us. Follow us. Give us the wheel of the ship, and we will turn this wreck, and we will improve healthcare. Follow us. If you want to know about how to find out how much things are, I haven't had insurance since I ended cancer treatment in 2008. I know how much things are. I tweet the prices of what I pay. There is a startup in New York that is crowdsourcing actual price information across the country. It's called clearhealthcost.com. And it's happening. You just got to watch us. The idea virus is right here in the front. Ask us.
Casey blew it out.
Mike here, there it is.
Hello, everyone. My name is Cisco G-III-I on Twitter, and I wear a number of different hats. The one that I'm coming to the microphone with is that of a researcher. And I'm presently doing my PhD with some data from patients like me and working with the Institute of Medicine. And what we're looking at is that 90% of Americans, this is Consumer Reports and Patients Like Me data, believe that their data is presently being used to improve future care. And 76% of them actually want their data to be used. However, policy is not there to protect them from discrimination or from health insurance coverage. And so, without trying to do too much self-promotion, what I want is your ideas of how the Institute of Medicine, or what we can recommend towards Congress to actually protect consumers so that they can share as much data as they want and there can be cross-pollination for data use. So it is more of an open question. I want to leave that thought. Please tweet about it. And if you can make it to my presentation, that'd be great tomorrow, because I need help. I need help. And I want help to be able to help patients share their data.
Well, my question to you is your study, you said 77%?
76%.
76% want to share the data. Was the follow-up question, was this only if it was kept de-identified?
No.
So
that
did even
actually,
ask?
I will talk about, yes, I will talk about that tomorrow. And the thing is...
No, I'm asking you now. Was that question even asked to these patients?
Yes, it was.
Okay, and what was the answer?
And so the interesting thing is 76% of them, 73% of them, sorry, off the top of my head, believed that the data they were sharing was going to be used against them. However, they were still sharing that data.
Right, so the default was they're willing to share even though it may be used against them.
That's correct.
Go for it then. Don't do it now. Change the world. Don't feel like you have to have any more holds stopping you from using that data and going forward with this. Find people like me and like Casey and e-patients up front that are willing to just share it with you. We'll share it with you if you can change things.
Right, but what I'm trying to say is not me. It's let's bring it to the policy level.
Yeah,
let's
I'm saying you
the
bring it to the
decision
policy level. You can go to federal meetings. Did you know that? You can have a PhD. You don't even have a PhD. Go for it. I only have a high school degree, and I go to policy meetings. This is the thing. Don't wait to change the world. You know this data. You've got statistics. Get out there and start talking about it.
The powerhouse. We're going to have to thank the powerhouse, Regina, who's Passion, Bercy, David, Michael, and Stephen. Thanks so much.
Thank you.